Good day. I'm Dr. Joseph Treat. I'm a professor of medical oncology at Fox Chase Cancer Center in Philadelphia. Uh, I've been a clinical trialist in lung cancer only for quite a while. I have a special interest and I'm part of a research group which I co-lead that is specifically looking at patients who are never smokers and trying to develop both new treatment options as well as looking at some of the factors that might be important at a preclinical level with collaboration with one of the more prominent scientists here, Dr. Margie Clapper, who does some preclinical laboratory investigation. And as a companion to that, along with Dr. Nick Boder, we are running or already have a clinical trial up and running dedicated towards this never smoking EGFR mutated setting. And so that's my research interest is very much in this area of never smokers who develop lung cancer. So a basic question is, what is a never smoker? And there are different definitions. Perhaps the strictest and the one that you typically see in clinical trials is this 100 cigarette definition, 100 cigarettes over a lifetime. More than that, you're a smoker. Well, I think we can all kind of see how that can be quite inexact in terms of what people remember, how they state it, how it's recorded, how it's transmitted to to data sheets. Yeah, so it's really is quite different. Almost every aspect of it is different, and the differences keep emerging. The first, the most graphic difference is the population, the demographics. They tend to be women, and there's geographic differences that are very profound. Western populations, such as here in the USA, Europe, only see about 10–12% of these tumors in these individuals having something called the EGFR mutation. Whereas in Asia, Japan, Korea, China, abundance of data shows that the rate of EGFR mutations is as high as 35–40%. So that's just a staggering difference. Besides these observable, quite apparent demographic differences, the differences in tumor behavior. These tumors tend to be a bit more slow growing. They are also more likely to be sensitive to chemotherapy, but curiously and importantly, they are not likely to be responsive to the really great development of the last several years, which is the immunotherapy type drugs. So they're just different almost any way you look at it. Treatment response, what they respond to, what the patient looks like, it's just a different sort. So this is one of the things that is kind of one of the leading candidates for explaining why checkpoint or PD-L1 inhibitors don't seem to work very well in this patient population. And it's kind of, you can kind of tell a story in a fairly direct way, meaning when people smoke, these over time, the tumors pick up, and over years, these cells pick up multiple mutations, tumor mutation burden, and they tend to be the highest in the tumor types that are the highest association with smoking, such as squamous cell, non-small cell lung cancer, and small cell. And as we know, small cell is almost 100% associated with smoking. Whereas this patient group, these women, never smokers, many times Asian, are the opposite. They are obviously never smokers. So tumor mutation burden in patients who are never smokers is very small. It's very light. And so what's the implications there? So again, in a general I'm not an immunologist, but in a general way of conceptualizing this, the cells that should be responsible for recognizing and attacking aberrant cells, cancerous cells, the T lymphocytes, if there's not a lot of mutational presence, a low mutational burden, in essence, they don't have much to recognize and see. And it's been well documented that if you look at tumor specimens, biopsies of individuals who have cancers that arise in never smoking situation, there's very little T cell infiltration. They're called cold tumors because there's not a lot of these inflammatory type cells. So it undoubtedly has some implications. This low TMB burden is a factor in why immunotherapies have not been very successful. There is an interesting data set from prior work with this drug that really needs to be pursued. There were a couple studies done quite a few years ago looking at chemo plus minus LP-300. And in later, much later after the trials were done, there was a retrospective subgroup analysis. Now, we always approach this with a grain of salt. We all know that retrospective analysis can be misleading. However, I think sometimes we see outcomes that are more compelling and sometimes very compelling than other retrospective analysis. And when you look at the retrospective analysis of these two different phase 3 trials that were done a few years ago, again, chemo plus minus LP-300, both trials on retrospective analysis showed very striking survival differences in the group that got LP-300 and were never smoking, or females, or both. And the differences here are not just 1 or 2 months, they're really almost double the expected survival time or the outcome data in the chemo-only arm. So this is a very dramatic difference, again, in retrospective data, but I think it really demands further looking. So it isn't just the retrospective data, because I think you obviously need some very direct preclinical data that gives a mechanistic explanation of why a drug is working in a particular situation. And the preclinical data here supports that this drug can be an important component of treatment in EGFR mutated tumor. It binds to the receptor, it binds to other receptors. So there's a mechanistic explanation. It also has some interference with some important biochemical steps in terms of chemotherapy drug activity. So there's more than one mechanism of action which directly supports using this drug in this type of population. We are very pleased that we're leading this trial across the country and internationally. Having said that, we do have a known track record of how often we can accrue patients with this type of epidemiologic background or demographic background, meaning never smoking. And these are tough trials to accrue in the United States. We anticipate in a year's time at this institution, which is a large urban-based center, that we probably will accrue 6 to 8 patients a year. And so obviously we'll need the help of other centers in this country, and likely more importantly in Asia, where the patient population is much more abundant in terms of the demographic that's appropriate. I should mention some of the working aspects of this trial. Who's eligible? What's the appropriate patient to consider referral to a center that has this trial up and running? So first of all, it is a patient with, it actually can be one of several different type of mutations, but EGFR, ALK, and some others are included. And obviously, just based on the numbers, EGFR will be the most common. Regardless of the mutation, they must have received an appropriate tyrosine kinase inhibitor. So in the case of EGFR, that's likely to be the well-known first-line choice drug. And for the other mutations, other TKIs as appropriate, they must have received them and had the disease progression on those. So we don't want to supplant recognized excellent first-line therapy. This is a second-line approach, and so that is important. The second thing is they have to have a demographic of a non-smoking background. So if one wants to see if this trial is applicable to any given patient, there are various ways to access. Certainly one can call the centers that have the trial up and running, such as here at Fox Chase in Philadelphia. Secondly, go to the web, to put in the search engine harmonic trial. It'll pop up, and you can pursue it that way.